Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So, how do we get there accurately? Well, your 75-year-old gentleman who has IPF may really not be interested in a right heart catheterization, but when you see him, you're going to have to tell him, my echo's great. I love it. I'm going to make you do a lot of them during your time spent with me as a PH patient. However, it's accurate less than 50% of the time. And this was a publication by Dr. Nathan looking at patients with interstitial lung disease, IPF. It overestimates about 50% of the time and underestimates about 10% of the time. So it gets you an idea where you're going, but definitely could not use this for diagnosis. So right heart cath is required. But when you get your right heart cath, you always have to step back and say, do I have the right diagnosis? Always with pulmonary hypertension, you want to make sure you're not missing something. And it's really important to make sure your right heart catheterization findings are consistent with the disease you're diagnosing the patient with. So this is a slide that just helps you understand that they should be concordant. You should not have a mean PA pressure of 80 and an FEV1 of 75% and blame it on pulmonary hypertension with ILD. So you want to make sure that your interstitial lung disease matches what you're seeing on your right heart cath. Otherwise, you got to look for other reasons. Do they have connective tissue disease? Have they been exposed to drugs or toxins that could be triggering this? So just an important takeaway. So after you get your right heart cath on your gentleman, what do you tell him? Well, Ioana already told you. Once you have pulmonary hypertension, it changes the trajectory of your disease. And if you look here, the black line with no pulmonary hypertension is so different than even mild pulmonary hypertension. Borderline here was a mean of 21 to 24. So even mild increases in pulmonary hypertension, pulmonary pressures portends a very poor prognosis. So this is something you don't want to diagnose and say, hey, I'll come back and look at it a year later. So if you look at here, 15 months, less than 50% survival. So what if you get a mean pressure of 19 or 22? How long do you wait to look at it again? Well, sometimes it progresses pretty rapidly, and everyone has had patients like that. The disease goes very quickly. But on average, in a group of nearly 100 pulmonary fibrosis patients, mean pressures increased by about 2 per year. So this is going to be marching along. As I mentioned earlier, it's a continuum. And those increases in mean pressures actually tracked with more mortality in this subpopulation. So important to know that this is something to follow, watch, and if you're in that borderline range where you may not want to treat yet, you're going to want to reevaluate and reassess with a right heart catheterization in the relatively near future. So one thing I thought was very interesting is this vasculopathy is impactful even when the pressures are in the normal range. If you look at here, the top line, the patients with mean pressures of less than or equal to 20, when their PVR was elevated, they had worse prognosis. So you'll see here that mean pressure, of course, tracks with worsening outcomes, but you see it starting even when the pressures are normal and that resistance is higher than it should be. So it's acting on this patient's quality, quantity of life very early on. So my key takeaways from this section: echo and right heart catheterization can be used to support and confirm the diagnosis of PH-ILD. And it's important to make sure you always have the right diagnosis and look at your patient globally once you diagnose them with pulmonary hypertension, making sure that you have concordance between the ILD findings and your pulmonary hypertension so you treat them with the correct medications. And any level of pulmonary hypertension with ILD is important. it impacts their outcomes significantly. And that change in pressure rising over time is associated with worse outcomes. So with that, I'm going to let Ioana take the stage.
Thank you, Jean, and hello, audience. Good to see everyone, old friends and new friends, I hope. So let's talk about what do we have any options for treatment for these patients with pulmonary hypertension associated with ILD. And again, this is one other study that to remind you that the presence of any level of pulmonary hypertension in patients with chronic lung disease is associated with significantly worse survival. So let's delve into, look at this. This is I think, Steve's idea.
That's my work of art.
This is your work of art. Yes, exactly. And we saw how to detect the presence. But when should we intervene? Because once pulmonary vasculopathy occurs and starts getting worse, there's a critical point where the symptomatology and limitations of the patient is not only due to the lung disease that usually is progressive, but is also the pulmonary vasculopathy that impacts the level of activity, the daily activity, the quality of life, not only their survival. So these two complex entities intersect and participate into the disease process. So we have to watch for an increase in mean PA pressure and PVR and a decrease in RV function as the pulmonary hypertension worsens. So how can we treat, and how successful have we been at looking for I wouldn't say a cure because we're far, but for a treatment for these patients? And we have been up and down, and I have to say, looking back, probably less successful than in the world of PAH. And we find excuses that it's a rare disease, PH-ILD, it's difficult to enroll, it is difficult to perform right heart cath in these patients, and so on and so forth. But actually, I think we just did not find the right medications until recently. So we have to continue to look for treatment. This is a table of the most important clinical trials that took place in enrolled patients with IPF, with or without clear diagnosis of pulmonary hypertension, but most of them had a suspicion of pulmonary hypertension that was indirectly evaluated by the need of oxygen, by the dysfunction of the right ventricle. And if you look at our success rate, it has been pretty low. On the contrary, we also identified therapies that we thought may work, but seemed to have a signal of more harm if we use them. So we have to be really, really careful and make sure that we understand, the clinical trial process and what studies were positive and what negative. For example, if you look at the bosentan, ambrisentan, and riociguat, unfortunately, they work very well in pulmonary arterial hypertension, but they do not work well in pulmonary hypertension associated with ILD. And up until 2020, our success rate was really dismal. The last study that I will be talking about is the INCREASE study that looked at the efficacy and safety of inhaled treprostinil, and that was positive. So it this inhaled treprostinil was approved by the FDA for the treatment of PH-ILD. So finally, we started having a treatment option that we can offer our patients. So looking at the INCREASE study, this was a multinational, randomized, placebo-controlled study that enrolled patients with different forms of ILD. A large proportion had IPF, and they were randomized to either inhaled treprostinil 4 times a day or placebo 4 times a day. The study lasted 16 weeks, and the primary endpoint was a difference between baseline at 16 weeks in 6-minute walk distance. So if we look at the after 16 weeks, patients were enrolled in the open label extension trial, where everybody was offered the active drug. So in the lower corner on the left side, you can see the change in the 6-minute walk distance in the placebo, which was the flat line going downwards actually, compared to the active drug that was the red line. And there was a statistically significant difference at 16 weeks in the distance in the 6-minute walk. Also, the different colors tells you that this change was studied in different statistical analyses to make sure that we understand the results correctly. There were other important secondary endpoints that you can see in the table up on the right that included clinical worsening and change in NT-proBNP. And clinical worsening included hospitalization, decrease in 6-minute walk distance by at least 15%, and lung transplantation or death. And you can see that it achieved statistical significance in favor of inhaled treprostinil. NT-proBNP, a marker of a stretch and overwork of the right ventricle, also improved. Now, we've used inhaled treprostinil for many years in the PAH group 1 patients. So we have a pretty good idea of the safety profile of the therapy, and also it's a prostacyclin. So we know a lot about this molecule. And in the PH-ILD study, in the INCREASE study, the safety profile of inhaled treprostinil mirrored exactly what we've known, so there were no worrisome adverse events. So the study was relatively short in duration, 16 weeks. And what does it mean to walk 30 meters more? How about, I'm gonna ask Steve, because he was the lead author of the study. Is it important 30 meters in a patient with ILD? If they can walk more?
I think it is. You know, if you look at what is commonly regarded as the minimally important difference, it is around 30 meters. But I think one thing to bear in mind is that that's the average for the group as a whole, and there will be certainly patients who don't improve that much, but there might be other patients who are so-called super responders who really have a really good improvement.
Yeah, yeah. So how about Jean?
This population is always going in the wrong direction when you follow them. To have anything that helps them is so hopeful.
Yeah, I agree with you guys. I think.
Sorry,
yes.
Just another point around that.
Yeah.
The original study that got inhaled treprostinil approved for Group 1 PAH, the TRIUMPH study.
Yes.
The distance was 21 meters.
Yeah.
This is 31 meters. And to Jean's point, if you go back and look at the change in the 6-minute walk, about 2/3 of that was improvement. And so anytime you can get a patient with fibrotic ILD to have any kind of functional improvement, that's a huge win.
Yes, because for now, what we treat ILD, we treat to delay the progression of the fibrotic disease. So if we can treat to improve the pulmonary vascular impairment in these patients, I think the patients will feel better. So let's look at the dose. Inhaled treprostinil was increased every 3-4 days, up to 9 breaths 4 times a day. And some patients tolerated even up to 12 breaths. So if we look based on the dosing at the percentage of patients with clinical worsening and with clinical improvement, and you can see the definitions here, you see the placebo arm, more clinical worsening, less than 5% clinical improvement. In patients who tolerated treprostinil less than 9 breaths, there was less, compared to placebo, there was less clinical worsening and started more improvement. But the best did the patients who tolerated 9 breaths at least 4 times a day. If you look, so it looks like it's a dose-dependent response. So the recommendation now is to try to push to the maximum tolerated number of breaths, at least 9. Now, feel better, do more, but also live longer. Those are 3 key important aspects and focuses that we need to think about when we treat patients in general, and now with pulmonary hypertension and ILD. But the INCREASE study was a short study because we wanted patients to be offered the open label extension after the main primary outcome was measured. So doing a survival analysis is very difficult when all the patients roll over to the active drug. However, very sophisticated and smart statisticians came up with several ways to measure and not to measure, but to estimate survival between the placebo group and the active group. And I can tell you it included both the randomized portion of the study and the open label extension study. And then there were 3 analyses, the intention to treat and 2 other more sophisticated analysis, one of which suggested that there may be an improvement in survival. This is the intention to treat analysis, which is a much more stricter and conservative, and it favors the treprostinil arm, although it doesn't reach statistical significance. But again, we didn't follow these patients too long to see a real difference. And then this is the second way to analyze statistically the probability of survival, which also favored the inhaled treprostinil. And then if we look at a different way to analyze, because we always learn from our cardiology colleagues, and I'm the first one to admit, they have an interesting way to measure effect in a clinical trial that's called a win ratio. And I think we should start implementing in our clinical trials a priori, because it's a good way to prioritize the key important points in clinical and endpoints. So death, hospitalization, decrease in 6-minute walk distance, and clinical improvement. And if you look at the clinical improvement, it clearly favored the inhaled treprostinil arm. So I know you probably know, but in Japan, you need to do your own study in Japanese patients in order to seek approval for the therapy. And this was a small open label clinical trial in Japan that enrolled patients with PH-ILD. And these are the results that showed improvement in the pulmonary vascular resistance, in NT-proBNP, in functional, actually KL6, which is a biomarker of the fibrotic lung disease. Steve, we don't use that here in the States much, but is it being used outside US?
It's used primarily in Japan. I think it might even be commercially available in Japan. And as you mentioned, it's a biomarker that reflects fibrosis. So it is interesting that KL6 went down, because in the INCREASE study, we got a similar signal of relative improvement in the FVC in the treatment arm compared to the placebo arm.
Yes, yeah. So it's interesting to see that if by delivering a prostacyclin, would you also affect the elasticity of the lung parenchyma, maybe?
It could be, but I think the prevailing hypothesis is that maybe it has independent antifibrotic properties, and as you know, that's currently being tested through the TETON study, which is ongoing and should be close to enrollment in the next coming months, hopefully.
Yeah, that's great. What's also very nice in the study is that there were right heart cath data, and you can see the average PVR that dropped from 6 to 3.5, which I think it is impressive. So was it approved in Japan?
As of last month, it was approved on September 24th in Japan.
Okay.
Nice.
All right. Now, this was a story with inhaled treprostinil and INCREASE study. Now, were there any other therapies that may have a signal? We don't know yet, although there was this interesting study in a small group of patients with PH-ILD that was not randomized. It looked at patient survival if they were or if they were not placed on a PDE5 inhibitor. And it applied sophisticated statistical analyses to account for the bias of non-randomization and non-blinding in this study. So, however, with this sophisticated analysis, these curves suggest that PDE5 inhibitors may have a role in the treatment of pulmonary hypertension. And what was interesting was that the survival difference may have been more significant in patients with less impairment in right ventricular function. So maybe an earlier, although I think we need to do a randomized trial to have a definitive answer. So overall, where is this is the treatment algorithm that we suggest. First of all, the INCREASE study and all the studies enrolled patients in with the old hemodynamic definition of pulmonary hypertension. So a mean PA pressure 25 or above and the PVR over 3. Now we lowered the hemodynamic definition to 20 and 2 Woods units. So in patients who present with pulmonary hypertension in this range between the new definition and the old definition, we don't have yet data on treatment. So the recommendation is to follow them closely and to repeat the echo and the right heart cath at regular intervals to pick the point where this disease progresses. Now, if they already have a PA pressure of at least 25 and a PVR of 3 or above, then you can offer them treatment. Of course, treat the underlying comorbidities, the hypoxia, the sleep apnea if it's present, signs and symptoms of heart failure, and so on. But the currently approved therapy is with inhaled treprostinil 4 times a day with an increases in doses. In patients who may not tolerate, or you think they may benefit from a PDE5 inhibitor, there is also a less stronger recommendation for the treatment with sildenafil. In patients who are severe, we recommend a referral to a lung transplant center as soon as possible. And always think about collaborating with a PH center or with an ILD center, because these patients are not easy to manage. So takeaway points for the treatment of pulmonary hypertension with ILD. We do have one therapy now, inhaled treprostinil, that has been approved to improve exercise ability among patients with ILD. It reduced clinical worsening in the INCREASE trial, and 2 independent analysis in a post hoc fashion suggested that there may be a long-term benefit in patients with PH-ILD. We recommend close monitoring for improvement, but also to follow up with side effects and potential worsening. There are two types of treatments that are clearly not indicated. Endothelin receptor antagonists and riociguat, they should be avoided in PH-ILD due to the negative studies that were conducted before, and PDE5 inhibitors can be considered in selected cases.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.